do a lot of spine degenerative diseases. I think 80% of our work is spine. So I thought I'll present on something called Facet syndrome. I think this is a syndrome which is supposed to be known to many of us, but slightly to push to one side. However, probably with this presentation, I think people will take home more of this, and this would be part of the evaluation of every spine surgeon when you look into conditions of chronic low back pain. So there are many things which can cause back pain: extraspinal causes, interspinal causes. Discogenic pain, considered by most of us as the most common cause of spine pain, which comprises almost around 40%. Another 40% is Facet syndrome, which is something which you should be all looking into. So I compared a couple of tests. I don't have the references here, but these are around 10 presentations used with use of ChatGPT. I compiled this chart, which shows that around up to 45% of chronic back pain comes in patients with Facet syndrome. It's almost as equal to discogenic pain. A few words into the nerve supply of the facet joint, why it is there. It is there because we need to walk, and for us to stand straight, like Dr. Nashwan said, we need messages sent to the brain so that we know our positions. So these are basically used for position sensing and also for management of our pain. So this is where you have most of your pain in degenerative facet joints. People who have degenerative facet joints, and you have a supply coming from the top as well as supply coming from the exiting nerve root itself. So there are two nerve roots, as always Dr. Mishwar mentions. It's a pair of synovial joints, so it will undergo all sorts of degeneration as any other joint would do, including facet degeneration leading to facet effusion, which could ultimately lead to pain. So pain mechanism, it's an inflammatory mechanism where you have degeneration followed by capsular tension and then impingement of these nerve roots when the facet becomes hypertrophic and osteophytes form around the joint, around the nerves itself. I would also want everyone to look at the pain pattern where sometimes we feel that pain should not be radiating if it's a joint. But facet joint pain is a referred pain which you could feel. Someone who has a facet syndrome of C4-5 level could have shoulder pain or could have interscapular pain as well. He might not, or she might not be having radicular pain which moves down the arm, but if you have your pain going down to the shoulder, you would think it's C5 radiculopathy one. Okay, clinical features once again. So this is a sort of axial back pain. Axial back pain meaning you don't really have radicular pain. Radicular pain is when you have pain radiating down the leg. But this particular type of facet pain can also have some degree of radiation, but it doesn't usually go beyond the knees. We all know that radicular pain usually goes beyond the knee unless it's L3. So looking at the x-rays, I think all surgeons look at this. Maybe we emphasize a little bit more on looking at the facet joints. So we can look for facet hypertrophies, osteophyte formations. So looking at this joint, you can see this is slightly better than this one. You have osteophytes which is already broken, and you have loss of the capsule itself. In this facet joint, you have a hypertrophic overgrowth, and this probably has some amount of, I think it's very visible, some amount of what do you call it? Yeah. So it's graded also. I'm also not very familiar with the grading of the facet joint. Looking at the MRI, I wanted everyone to look into this. These are very common areas where we tend to think, okay, why is the patient having leg pain when there is no nerve root impingement? These are the places where your nerve root comes off. This is your central canal, this is where your nerve root comes off. But because of the inflammation in this joint, where you have a little bit of fluid here, little bit of facet joint effusion, which is not there in this side. Because of this pro-inflammatory mediators all around this nerve root, all around this neural foramen, you have radicular symptoms as well. In this area, in this particular one, you have a hypertrophic facet joint, which is not encroaching onto the nerve root yet. So, how do you manage these patients? So, someone with facet joint syndrome, which is a clinical presentation, they might not have pain itself. Someone who has a facet effusion or someone who has facet joint degeneration at multiple, let's say an 80-year-old, definitely she would have facet syndrome, facet degeneration, but they don't have pain. This is where we end up not being able to identify whether these patients are really having facet syndrome or not. That's when you have a diagnostic technique which uses blocks to find out whether the patients are really having facet pain. You give local into the facet joint, any sort of local, long-acting, short-acting, ideally short-acting facet joint. If they have reduction in pain more than 50% in 2 consecutive times, in repeated attempts also, if it works, then it is facet joint syndrome. And these patients will benefit with a little bit of patient will benefit with conservative management. Of course, we always try for conservative management. This is a joint, so joint pain will always be treated with NSAIDs and all sorts of physiotherapy and strengthening and posture corrections. However, they are much better treated if you can give a facet block. So, who benefits with a facet block will ultimately benefit with radiofrequency rhizotomy, meaning you place a radiofrequency ablator into the level where you think patient has facet joint syndrome and ablate the nerve. It's like burning the nerve. Once you burn the nerve, it might come back because peripheral nerves, this is sort of a peripheral nerve, it can regenerate a bit more. So they might last for 6 months to 18 months, but they will work. So these patients come back and say, I have 80% reduction. So, surgery has a role. Initially, when I started also, I had this particular patient. We have gone in and done surgical facet, and patient did not do well. And we all know if you fuse a joint which is in pain, then they will ultimately have less pain. That's what orthopedicians are good at. So, North American Association of Spine Surgeons also recommend this procedure as one of the best procedures for facet pain. And newer inventions, Dr. Kiran and myself, we have done a very short training. Dr. Kiran did a longer training than me in endoscopic spine surgery. In endoscopic spine surgery, it's coming up where you can go in and do a pinpointed nerve root ablation with endoscopic techniques for radiofrequency ablation. If not, you would have to go in with a fluoroscopic marking and then imagine that the nerve root is going to be there. But in this case, you can really visualize it and ablate it. So my take-home message for all of you is facet joint dysfunction leads to facet syndrome, which accounts for 50%, nearly 50% of chronic back pain, and this is a syndrome which should not slip under our evaluation of any patient with chronic back pain. Thank you very much for this.